Welcome, everyone. Today, we're jumping into a topic that is absolutely fundamental to clinical medicine: sodium balance. Look, getting this right is critical for your patients, and getting it wrong, well, it can be disastrous. So let's really get into it.
Okay, picture this. You're on call. A patient comes in, confused, actively seizing. The labs come back and their sodium is a critically low 114. The pressure is on. This isn't just a random number. It's a sign of a massive physiological problem. By the end of this session, you're going to understand exactly what's happening inside this patient's body and how to manage this situation without making that one fatal move.
So here's our game plan for today. We're going to start with the basics, understanding hypovolemia. Then we'll do a really deep dive into our main topic, hyponatremia. After that, we'll look at its opposite, hypernatremia. And finally, we'll wrap it all up with some real-world clinical cases to see how all these principles come to life. Okay, first things first. We have to build our foundation with hypovolemia. You see, this isn't just about being a little thirsty or dehydrated. It's a very specific state of volume loss that really sets the stage for a lot of the electrolyte problems we're going to talk about. So what exactly is it? Well, hypovolemia means you have a deficit of both sodium and water. It's a loss of total volume from the extracellular space. That's the fluid that's outside of our cells. And that is a really important distinction because it's different from simple dehydration, which is mostly just a loss of water. So where does all this salt and water go? Well, you can think of it in two main buckets. First, you have renal loss, meaning it's lost through the kidneys. This can be from kidney damage like acute tubular necrosis or, and this is super common, from diuretics, water pills like thiazides or the really powerful loop diuretics. It could also happen if you're deficient in the hormone aldosterone or if you're on a drug that blocks it. The second bucket is non-renal loss. This is everything else, things like bleeding or GI losses, and there's a cool clinical pearl here. Vomiting tends to lose more chloride, which leads to an alkalosis, whereas diarrhea loses bicarbonate, leading to an acidosis. You can also lose volume through your skin if you have a fever, or through something called third spacing in states like sepsis or bad burns, where fluid literally leaks out of your blood vessels into your tissues.
Okay, so how do you spot this in a patient at the bedside? There are some classic signs. You look for orthostatic hypotension. That's when their blood pressure tanks by more than 10 to 20 points when they go from lying down to standing up. At the same time, you'll see orthostatic tachycardia, where their heart rate jumps up by more than 15 to 20 beats a minute, trying to compensate. These aren't just numbers. They're huge clues to your patient's volume status. And of course, you'll see the classic signs like dry mucous membranes and decreased skin turgor, that thing where you pinch the skin and it doesn't snap right back.
All right, let's move on to the main event, hyponatremia. This is, hands down, the most common electrolyte disorder you will see in hospitalized patients. It's filled with all sorts of clinical subtleties that are just essential to master. The definition itself is super straightforward. Hyponatremia is simply a plasma sodium concentration that's less than 135 millimoles per liter. That's the number. When you see it, the alarm bells should start ringing. But why does this one number matter so much? Well, first off, it is incredibly common. It affects something like 20% or 1 in 5 patients in the hospital. Now, the way it causes harm is all about osmosis. When your blood sodium is low, your blood is more dilute than the fluid inside your brain cells. So to balance things out, water rushes into the brain cells, causing them to swell. This is called cerebral edema. And that swelling is what causes the symptoms: the confusion, the falls, the weakness. And if it's really severe, say under 120, or if it happens really fast, you get seizures. And here's the absolute key takeaway. Almost all hyponatremia is caused by an increase in a hormone called arginine vasopressin, or AVP, which is also known as antidiuretic hormone. It's the hormone that tells the kidneys to hang on to water. To figure out the cause, the very first thing you do is assess the patient's volume status. This breaks hyponatremia down into 3 big types. First, there's hypovolemic hyponatremia, where the patient is low on both salt and water. If it's from non-renal causes, like diarrhea, the kidneys are desperately trying to save sodium, so the urine sodium will be low, less than 20. But if it's from a renal cause, like diuretics, the kidneys are actually wasting the sodium, so the urine sodium will be high, over 20. Second, you have hypervolemic hyponatremia. This is the patient who has way too much total body fluid. They look swollen, odomatous. You see this in heart failure and cirrhosis. And third, there's euvolemic hyponatremia, where the patient's volume status looks pretty much normal. This is the category for things like SIAD, the syndrome of inappropriate antidiuretic hormone, and in this case, the urine sodium is typically high, over 20. Now, here is a fantastic diagnostic clue that can help you tell the difference between a couple of those types. It's the serum uric acid level. You see, in hypovolemic hyponatremia, the body is trying to reabsorb every last bit of sodium it can in the kidney's proximal tubule. Well, it turns out that same mechanism also ramps up urate reabsorption, which leads to a high uric acid in the blood, or hyperuricemia. In contrast with SIED, that whole transport system in the proximal tubule is suppressed, which leads to a low uric acid, or hypouricemia. It's a simple blood test that can really help point you in the right direction. Now we're getting to what is probably the single most important distinction in all of this: acute versus chronic hyponatremia. The magic number is 48 hours. If the sodium has dropped in less than 48 hours, it's acute. This is bad because the brain has had zero time to adapt to that osmotic shift. The risk of that dangerous cerebral edema is incredibly high, and you have to treat it promptly. But if it's been developing for more than 48 hours, it's chronic. And in that time, the brain has done something amazing to protect itself. It actively pushes out substances called organic osmolytes, things like creatine and taurine, to lower its own internal concentration to match the blood. This is a life-saving adaptation, but it also creates a huge risk if we then try to correct the sodium too fast. And this right here shows you exactly what that risk is. It's called osmotic demyelination syndrome, or ODS. Let's walk through it. Step 1. In chronic hyponatremia, the brain has adapted. It's gotten rid of its osmolytes. Step 2. We come along and raise the plasma sodium way too quickly. The rule of thumb is no more than 12 millimoles in 24 hours. Step 3, this creates a massive osmotic pull in the opposite direction, and water is now violently ripped out of those adapted brain cells. Step 4, this cellular dehydration causes irreversible damage to the protective myelin sheath around the neurons, especially in a part of the brainstem called the pons. The consequences can be absolutely catastrophic: paralysis, inability to swallow, or even a horrifying locked-in syndrome. This is that fatal move we talked about at the very beginning. So since the stakes are so high, you absolutely need a systematic approach every time. First, you have to get a plasma osmolality and a spot urine sodium concentration. These are your most important initial tests, period. Second, get a full chemistry panel. Make sure it includes urea, creatinine, that super helpful uric acid level, and of course, potassium. And third, because endocrine disorders can cause this, you need to screen for them by checking thyroid hormone levels and a cortisol level. Okay, we have a really solid grip on hyponatremia now. So let's flip the coin and take a look at the opposite problem, hypernatremia, which is when the sodium level gets too high. Hypernatremia is defined as a plasma sodium over 145. Now, unlike hyponatremia, this condition is always a hyperosmolar state, which just means the blood is too concentrated. This high concentration pulls water out of your body's cells, causing cellular dehydration. The group that's most at risk here are elderly patients, because they often have a decreased sense of thirst and don't drink enough. Common causes include GI losses, like diarrhea, and a really key renal cause is the osmotic diuresis you see with uncontrolled diabetes. All that sugar in the urine just drags water out with it. And just like with low sodium, the symptoms are mainly neurological because the brain cells are shrinking. This can cause anything from confusion and lethargy all the way to a coma. All right, we've covered a ton of theory. Now it's time to apply it. Section 4 is all about seeing how these principles actually play out in the real world with real patients. So here's our first case, and it might sound a little familiar. We have a 62-year-old woman brought in by ambulance. She's been vomiting, and now she's having seizures. Her sodium comes back at a critically low 114. You look at her chart, and you find the key clues. She's on oxcarbazine, an anti-epileptic notorious for causing low sodium, and indapamide, a thiazide-like diuretic. The diagnosis here was SIADH, with her medications being the main culprits. Now, because she was having active, life-threatening seizures, she was treated with 3% hypertonic saline. That's a very concentrated salt solution that we use to carefully bring the sodium up just enough to stop the seizures. And the treatment worked beautifully. 5 days later, her sodium was up to 127, and she was awake, conscious, and talking. It's a fantastic outcome that came from applying these principles correctly. Case 2, however, is a much more sobering story. This is a 79-year-old woman who came in with an aspiration pneumonia. She was treated with fluids, specifically 5% dextrose in water, which for all intents and purposes is just free water. This treatment actually caused her sodium to shoot up to around 150, a state of what we call iatrogenic, or treatment-caused hypernatremia. Her condition never really improved. Her swallow was poor, she aspirated again, and sadly, she passed away. It's a tragic reminder of how our own treatments can create dangerous electrolyte problems in our most vulnerable patients. Now, these last two cases show us a completely different but equally vital pitfall: pre-analytical errors. In case 3, a lab result comes back showing a dangerously high potassium of 6.1, but then you find out the blood sample sat around for 5 hours before it was processed. A repeat sample comes back at a much more reasonable 5.1. Same thing in case 4, an 82-year-old has a potassium of 6.3. She gets sent to the hospital, but when she gets there and they recheck it, it's only 5.5. In both of these cases, the diagnosis wasn't a real medical problem, but a lab error called pseudo-hyperkalemia. If the sample sits too long, potassium can actually leak out of the red blood cells right there in the tube. It's a huge lesson. You always have to think about the journey the sample took from the patient to the lab. And that really brings us to the final, most crucial point of all. A lab result gives you a number. But is that number the physiological truth? As we've seen today, the answer depends on so much more. It depends on the patient's volume status, on how fast the change happened, and even on how the blood tube was handled on its way to the lab. Understanding that entire context, the clinical picture, the timing, the pre-analytics, is what separates just treating a number from actually truly treating the patient. And that is what allows us to navigate these tricky situations safely and effectively.